Dr. Chunhuei Chi is a professor of Health Administration International Track at OSU and was in the original team that helped develop the universal healthcare system for Taiwan in the mid-1990s.
Oh, yay.
He conducts studies all over the world for public health and teaches many of our leaders that go back to their countries to improve their healthcare systems. We happened to go to the same church, and in February 2020, he took me aside after service and said, this is what's likely to happen. And unfortunately, I couldn't believe what he said, but it all came true.
Came to pass.
Yeah, it did. It came to pass. And so he's a wonderful person to know, and been very generous with his time in helping us understand public health and pandemics. So, Dr. Chi.
Thank you, Mike, for a very generous introduction. Mike asked me to do the talking I gave 2 weeks ago for the one-payer state. And Mike, I assume this will be the same format. I will talk roughly 20 minutes followed by open discussion, right?
Yes.
Okay, I am going to share my screen. Yes.
What is the OECD? What's that acronym?
OECD is the acronym for Organization for Economic Cooperation and Development, which is a euphemism for High Income Countries Club.
Okay.
So OECD used to be about 30 countries, but now they added a few. Some of the former Eastern European country and South Korea, Chile, these are the newcomers. So they represent the world's high income country. So this was the original talk Mike asked me to give for the one-payer state. So in today's talk, I have 3 brief sections. First is an overview on how we see equity issues in healthcare, particularly under the universal healthcare system. And then the second part, we'll talk about equity in healthcare among OECD nations. Share with you some of the comparison. And lastly, we will discuss about what are the lessons we can draw for the United States. So the first part, I'd like to briefly introduce about some of the epistemological and philosophical issues behind universal healthcare. And my mentor, some of you have met Bob Evans, who I invited to be a keynote speaker in 2018's OSU International Symposium on Universal Healthcare. He was the keynote speaker. And he has this very famous quote about the fundamental question on health system financing. And he loved wordplay. So basically he summed it up to who pays, who gets it, and who gets paid. And today we will talk about the first two. The last one has to do with the reimbursement system. So we will not touch on that today. But we'll, in terms of equity, it concerns the financial burden, who pays. And then it also concerns the access and utilization of healthcare, that's who gets. And I try to summarize key factors that shaping a universal health system. So you have the distribution of political economic power that interact with historical institutional development, as well as prevailing social values. So these 3 major factors interact with each other, they shape with each other. In the end, they also shape how and what kind of, or even at the first step, whether a country develop a universal health system. In 2016, I was invited to give a talk in an international symposium in Chile. And I developed this comparison for that specific presentation. on social and ethical foundation of health system and health care. So I use a very simplified two philosophy comparison. One is the very popular assumption in the US health system as an industry versus for most countries with universal health care, they see health system as not just an industry, but a social institution. And so with these two different philosophical views, you have different ethical or political foundation. The individualism, neoliberalism versus communitarianism or socialism. And then the nature of healthcare in industry perspective is treated as commodity, a private good. But in the social institution perspective, it is treated as community commodity and merit goods. The method of allocation in industry is free market. And then for the social institution, it's state responsibility. The function of health system for the industry perspective, it is employment, financial investment services, and economic growth. But for the social institution, the function of a health system is promoting health and also promoting a just and caring society. And the significance of national health policy in the industry perspective is insignificant. But in the social institution perspective, it is usually well aligned. Governance in industry is individual agency. And then in the social institution is community shared agency and governance. In terms of equity in health and healthcare, there are more than a dozen different ethical principles. I'm just going to highlight in 4 of the more popular ones. One is equal access for healthcare. And then there's equal access for equal needs. And the third one is equal access for equal ability to benefit from healthcare. And the UK's National Health Service follow this principle. And then in terms of equity in financial burden of healthcare, amazingly, most countries have a rough consensus following this principle, the ability to pay principle. Those who are able pay more. But there's an emerging new concept in terms of equity in universal health system. That is the equality in quality of healthcare. And equity in other dimensions are also being brought up associated with health and healthcare. For example, social care. And then ultimately, we want to see is equality in health. And then in terms of how we measure equity in healthcare, there are different choice of focal space of equity in health, ranging from life expectancy at birth to mortality, morbidity, life years, or composite score such as quality or quality. But then there are non-health indicators such as waiting time, financial burden, medical debts. And then a whole different issue is whether we put weight when we measure them. So that's a quick overview on some of the philosophical foundation, how we see equity in healthcare and the universal healthcare. So the second part, let's look at equity in healthcare among OECD nations. And I'm going to show a series of comparison statistics. There are 3 dimensions of healthcare coverage. You have the population who is covered, and then you have service, which services are covered, and then you have the direct cost, what's the proportion of services covered. And this 3 dimensions can shape a country's universal healthcare in different size, different shape. And the revised OECD framework for performance measurement look at equity on the vertical and then efficiency on the horizontal. And within them, they have quality, access, cost, etc. And access to affordable health care, there are possible hurdles and related inequalities scenario. So you have the issue on utilization, and then you have the issue of utilization but financial hardship, and then you have unmet need. This has been one of the most commonly used indicator to measure a society's healthcare system in terms of its ability to promote health. And this measurement is looking at mortality amenable to health care between 2000, that's the light blue, and 2016, that's the latest statistic available. If you look at the 2000, the US, among this group of country, selected OECD country, mostly European and Canada and Australia, US ranked the last, but not too far behind other countries. But 16 years later, US not only still ranked the last, we have the highest number of mortality that can be prevented, because these are totally treatable conditions. People die from treatable conditions. And US not only remained the last, but also the gap widened between US and the other country under comparison. And this next comparison, look at the seniors more likely to be sick and have trouble affording care than those in peer nations. So the dark blue are older adults with 3 or more chronic conditions. The green are older adults having problems getting care because of cost. So again, US has the biggest problem of access and in terms of cost. This next one compared proportion of the population foregoing care because of the cost and by income quintile. So on the right hand, you have the lowest income quintile. On the left side, you have the highest income quintile. And so when that range between the highest and lowest income quintile is wide, that demonstrates a wide gap, means wide gap of inequality. And the OECD average is right in the middle. And US is not included in here in this comparison because the statistic gathered in the US was incompatible with the rest of the OECD country. Likewise, France and Sweden also excluded. And this is the gap in life expectancy. So this compare life expectancy between the highest and lowest income quintile. So for example, Slovak Republic has the widest gap on life expectancy at birth between the highest income and lowest income. It's about 10.5 years. And this one includes US. This is the needs standardized probability of a doctor visit in the past 12 months by income, again, using income quintile. So the dark one are the highest and the light one on the left are the lowest. So United States is right here. So our, we still have a wide gap, but also our average is also behind most of the OECD country. And similarly, this is for hospitalization, and US is here. And this is the inequality index of the probability of a doctor visit after needs-based standardization. And US is here. And also we represent a wide range. This next one compare out-of-pocket spending as share of total health expenditure in 2016. United States fared relatively well compared with other OECD countries in terms of out-of-pocket spending in 2016. This next one look at affordability of healthcare services and its relationship. So we can see the trend that the share of out-of-pocket total health spending as it increased, there's also proportionally share of household with affordability problems. And this compares the household with catastrophic out-of-pocket spending by consumption quintile. So the darkest blue is the poorest quintile. The white one are the richest quintile. And these are the share of household with catastrophic out-of-pocket payment. So the last section, let's look at what kind of lesson can we draw from OECD comparisons. Before we do any lessons, I'd like to remind everyone that there's an important issue to consider is generalization versus contextualization. And there are variations in our health system, including values, the social values, goals, functions, culture, norms, and motivation for action. So to what extent we can generalize and to what extent we have to contextualize, it all depends on how those factors varied across country. And this next one, look at the United States, person who age less than 65 years with health insurance by income from 1999 to 2005. And the top line is the high income. So this is not by quintile, this is by quartile. And so the bottom dotted line are the poorest 25%. So between 1999 and 2005, very consistently, there's a huge gap about accessibility to health insurance across the income quartile. And the bottom one consistently have the poorest access. Similarly, the health insurance coverage and type by income to poverty ratios. For the private health insurance, a person whose household income of 400% at 400% or above poverty have the highest rate of coverage. And the share of adults who have medical debt by household income and insurance status in 2019. In the US, in 2019, 9% of the population adult have medical debts. And then when we look at the income level, and of course, the lower income have a higher percentage of household with medical debt. However, it's quite surprisingly, even for the very high income, who are 600% and above poverty line, they still have 4% who have medical debt. And recently, OECD, they have developed coverage principle to promote equity. One is considering the level of insurance coverage. And the next one is the breadth of coverage, population who are covered, the scope of basic coverage, and then the depth of coverage in terms of the service benefit covered. And this is an example from the UK. They developed 7 key societal investments for improving health equity over the life course in the UK. I highlighted some of the key points. In very early life, family planning, prenatal and perinatal care, and out of poverty, taking care of people out of poverty, and then early childhood education programs. On the later childhood and adolescent, universal secondary education and training. And then throughout the lifespan, accessible high quality primary, secondary, and tertiary health care, and control on established health hazard and appropriate employment. And this is a comparison on one of the study that comparing the panel regression on on estimated efficiency measurement, and US is kind of an outlier. So this chart look at potential gains if the health system can improve. How many years of life can potentially be gained? And US has the highest to gain potential life, 7 years. And this one also compare health system performance comparing with spending. So high health system performance versus high health care spending. So US is located at the worst corner. High spending, low system performance. And this comes from the Telegraph's 2016 publications, looking at affordability and quality quadrants. So the upper right is the best quadrants, affordable, high quality. The lower right is expensive, high quality. Upper left, affordable, low quality. Lower left is expensive and low quality. And US is right here on the lower left. There are common challenges in universal health systems. One is solidarity and sharing capacity, which is sometimes we call sustainability. And then there's equity concern and efficiency concern. And governance is increasingly becoming an important subject in universal healthcare. But in the US, it's largely escaped the focus of discussion or debate. Because under our current system, not only the average voters, even policymakers and academics, they cannot imagine the issue of governance. So when we look at the health system performance, we have to ask success in what? Are we looking at delivering healthcare services in terms of output, improving health outcome, health system strengthening? So the top three success measurement or object are commonly used direct to health. But then increasingly in OECD countries, they are also looking at the measurement or goal beyond health, such as number 4, improving social equity. And number 5, a better society for all. And both 4 and 5 were actually initially proposed by government. Let me briefly touch on health system and governance. As I mentioned, this is largely escaped the discussion and debate in the United States. The nature of governance determines objective and priority of the system. And it determines who has access to healthcare and who makes the most important decision about the health system. And who decides the governance structure and process. And finally, who is accountable under our current system, no one is accountable to our health system. And this is an example. One of my former PhD student and I, we did a research in Chile on the subject of governance. And more specifically, we asked sample Chilean people, what do they think are the most important ethical principles to governing their national healthcare system? And we use this example with pictures of 3 persons with different health conditions, and let the sample subject to choose which ethical principle they think should governing their national healthcare system. And because the ethical principle is so abstract, it's hard for them to envision, to imagine. That's why we use the chart to make a concrete example. And we have an introduction to our sample telling them which ethical principle you choose have a direct implication on, in this example of heart transplant, who gets a priority to get the heart. And in addition, in our survey, we also asked the Chilean people what type of health care that they see as a priority to improve within Chilean health system. So in the result for the distributed justice principle, there's not a single majority, but the 2 got the relative majority. One is 1/3 of them choose equal access for healthcare. And then another nearly 30% choose equal access for equal ability to benefit. So this is an example of how to facilitate governance, you have to involve the general public to think, to consider hard questions and make value judgment. Finally, the nature of a healthcare system, how we see it. I like first quote Governor Mooney. He said, it reflects what sort of healthcare system do we as a community prefer? And that question then leads to another more deeper question. What sort of community would we prefer to live in? And I commented in my conclusion in the 2008 Oregon Health Forum, I was invited to give a presentation. I said, a country's healthcare system tells us about the nature of the people and the society. And this is to reflect Governor Mooney's comment. So healthcare system is a test of who we are as a society and as humans. Do we include or exclude people? Can we work together or we have to work alone? And is our health system comfort people or inflict people? And is our health system to enrich society or to enrich a few? So that's conclude my brief presentation. And now we open up for discussion.
Wow. Thank you very much. That was very helpful. Questions, comments, reactions? Bobby?
I noticed in one slide in particular that showed that Britain had the smallest gap between the people who were doing well and weren't doing well in health. I think that was what it was. Britain was a tiny, small gap. And that was, I thought, very good. And it related to when you showed the 7 principles for health, they were from the UK, right?
Yes, yes.
And that went along, to my mind, with that finding that the UK had this smallest gap, I guess, between the highest and lowest healthcare of the population. I mean, you went through them very quickly, but that was one thing that I certainly noticed. And we all know the UK has had a very long all people in, no people out system. So they've had a long time to work on those, and they've developed a way to do it as a more truly socialistic than, for instance, Canada or some other countries. Anyway, I thought it was very interesting.
Yeah, thank you. Let me also comment on the UK. One of the strengths in UK in recent year was they dramatically expand and strengthen their primary care level. And the impetus for that strengthening came in 2002, that after EU research looking at quality of healthcare across EU, and UK didn't rank very well within the EU, but what struck the British people most was the UK's healthcare quality overall was ranked behind Spain.
Mm.
And if anything that can step up national spirit, that's when they found out they're behind Spain. And so they, because of that comparison, they see that as a national shame.
Yeah.
And they went through soul searching and dramatically revamped their primary care. And they also introduced a new concept, but unfortunately that concept didn't seem to be stick around for a long time outside of UK. The gatekeeper concept actually started in UK, but at that time when they want to revamp their primary care, they try to discard that concept, that term, gatekeeper, which sounds very negative. So they replaced the term gatekeeper with a more positive term. They call guardian of health. The primary care doctor as guardian of health.
Yeah.
But it's more than just replacing the term. They dramatically revamped their primary care, including local small hospitals. So for people who have chronic condition or who don't have serious condition that doesn't need sophisticated equipment or surgery team, they would like to put them in local hospitals so people don't have to travel far away. And they are more closer to the community, as well as strengthening their public health nurses' role in primary care beyond the clinic hospital and go into the community. So these are some of the effort UK did after 2002 to strengthen.
Mm. And it paid off, I think.
Yes. And I saw, Alex, you have your hand raised.
Yeah, thanks, Dr. Chi. That's funny, you commented about them having hospitals close to people. Now we're closing hospitals here, so kind of shows a little difference there. I had an observation. I wanted your comment on it. I've seen a slide, and I can't remember if it's our slide or OHA slides or task force or what, but showing the levels of care and satisfaction of care, and it shows, you know, pretty much everybody who's under senior level, like pre-65, is pretty low, and then after 65, it's high. So seniors are obviously, you know, seniors are getting are satisfied with their care, and you know, that's indicative of Medicare, right? So, but I was just wondering, because you showed a slide that showed the U.S. was kind of behind the times as far as seniors with chronic conditions or whatever. So I just wanted your reaction to that. Are those slides they're showing people, you know, satisfied and getting good coverage on Medicare? How does that jive with your slide there?
I don't think there's a conflict of that in terms of overall Americans who have access to health care are consistently quite satisfied with their health care. what they are not satisfied generally is the financial burden, particularly medical debt. And so, and also in terms of the people who are 65 and older who are eligible for Medicare, shows the high level of satisfaction of their health care. But this is just within country comparison. And generally, most people are not aware of how people with comparable age group in other countries are fair. And so I don't think that, personally, I don't see there's any conflict of those two statistics.
Okay, so even though our seniors are satisfied, if they knew how other seniors were doing in other countries, they would be less satisfied.
No, not that they will be less satisfied. They are satisfied as the way they are now. But let me put it this way. Our seniors don't know what they are missing.
Okay, thank you.
The seniors, they went through younger age of experience. So they knew the issue. They are accustomed to the kind of health care we have in this country. And there might be, let me put it this way, they have a lower expectation compared with other countries.
Okay,
Oh, that makes a lot of sense.
thank you.
Mike?
Yeah, I'm aware that there's effort to privatize healthcare in the UK, and that even some of the leaders of the NHS were once United Health CEOs or vice presidents. Can you tell whether that is adversely affecting the quality of healthcare in the UK yet?
Not that I know of, but the privatization of NHS, it's not a complete privatization, it's a marginal privatization, has been done for more than 3 decades. And at different point, they experiment different approaches. In the first decade of attempt to privatization, that was during Margaret Thatcher. And Margaret Thatcher, she really hated NHS, and she tried to dismantle NHS without success. And so that failed attempt, many researchers and policymakers use that as an example to show how NHS is deeply rooted in British society, that even a champion for neoliberalism like Margaret Thatcher couldn't shake it. But then in 90s, Tony Blair tried to experiment a different way of, it's not really a privatization. They just Tony Blair want to introduce competition. And he want to introduce competition within NHS, the providers and hospital competition. But that experiment didn't result very well, not well received. And so from time to time, they want to introduce some mechanism from the market to tweak it to see if it can improve their current NHS systems. And so the latest experiment, it remains to be seen how that can impact the quality of care within NHS. Earlier, I saw Jenny raise hand. Jenny is no longer here. Okay, Warren.
She's got it.
Oh, Jenny, we
sorry.
can't hear you.
Your speaker, you're not muted, but
Oh, I'm sorry. I moved up my speaker. Or my so my question was, so in the US, there's this waiting time for a lot of people until they get to be age of Medicare. right? So you have a lot of people between the ages of 50 to 65 who are underinsured.
Yes.
And in that, like, people don't want to change their job because, or maybe resign from their job because then they will no longer have insurance. I was wondering if you had any data on that as far as the population for the US.
I don't have specific data for this age group. You're talking about 50 to 65 who are near retirement but not retired yet, and then some of them are underinsured. I don't have data on that. I only have the updated data on the total uninsured over the last decade. And I saw a dramatic improvement since the Affordable Care Act. Before the Affordable Care Act kicked in 2014, we used to have very persistently about 13 to 14% population uninsured. And again, sometimes there's a mixed up of statistic.
Mhm.
So there are two kinds of statistics. Sometimes they are mixed up. One is the total population uninsured. The other is people who are under 65, meaning non-Medicare population uninsured. So if the statistics specify the total population, usually you see as a lower figure, like 13, 14%. But if the statistics specify it's under 65 adults and children, then you will see a higher figure, like 18, 19%. So,
Yeah.
but sometimes people don't explicitly specify that, make it hard to compare. So I'm talking about the total population.
Mhm.
Uninsured before the ACA was about 13 to 14%. But since 2014, since the ACA implemented, over the last 8 years or so, 7 years, it steadily declined to 2020, declined to 8%.
Mhm.
But at the same time, I also don't have the latest update on the underinsured. But based on the previous trend, researcher has tracked uninsured and underinsured since late 1980. Quite persistently, the percentage of population underinsured are about the same as the percentage of population uninsured. That means if the trend was consistent, when we observe 8% population uninsured, we may expect another 8% population underinsured.
It would be also interesting to look at the states which expanded Medicaid, and those that didn't too. I mean, because we saw a huge influx of OHP patients after the ACA, which was awesome. People who had finally had access to healthcare.
Yeah,
Was awesome.
Compare with most other states, Oregon's Medicaid are considered relatively more generous in terms of eligibility. Because when we implemented OHP, we improved it from previously, before OHP, the eligibility had to be about 25% poverty line. And since OHP, we improved it to 50% poverty line. And for pregnant women and children, we expand the access to 188% poverty line. Thank you for your question and comment. Warren, you have question or comment?
I'll read 3 comments that the task force has received in the public engagement sessions, and I would like your reaction. Comment number 1, I have a healthy lifestyle which enables me to purchase a high deductible plan at half the cost. I will never support a plan which punishes me for other people's bad choices. 2, if we allow everyone to access care, then the general public will have to wait in long lines and not get the care that we should be entitled to. 3, I could never support a system where we can't charge extra to the bad drivers, unsafe workers, people who allow themselves to be chronically ill. What reaction do you have to those comments?
So the first one, individual not willing to cover so-called other people's unhealthy behavior. The key issue is those people are not aware of uncertainty. An important nature of health and healthcare is uncertainty. And even for a perfectly healthy people, he or she may not know when and how the certain disease will strike. And the current pandemic is a good example. And the current pandemic exposed one interpersonal variation issues. Besides people who have chronic conditions, there's also individually, we have variation in our immune capacity or immune response. Even for a healthy person who have no chronic condition, there are also wide range of interpersonal variation in terms of immune response. And I don't want to sidetrack too much, but because I have been, since the pandemic, I have been focusing a lot of my effort and research on the pandemic. And there are researchers who try to find out why there are people who were never vaccinated and who were exposed to family member who got infected, but never get infected. And these are the people with very strong immune response. The preliminary finding is previous time they have exposed to different coronavirus. And because of their relative strong immune response, even though they were not vaccinated, even though they were exposed to family members who were infected, but their immune system was so strong, even without vaccination, they survived without any infection. So this is just an example to show even among healthy people, there are variation in immune response. And unless you have a long-term track and testing, we don't know how well, even for a healthy person, we don't know how well is our immune response. And then not to mention about accident and other environmental factors. So I think the key issue is to what extent does one person have control over her or his health? And there's a misperception. Many people who have that kind of thinking mistakenly thought they have near full control of their own health. And there are numerous studies ranging from a wide spectrum of social determinant of health, who the researcher estimated that in terms of the extent we have control over our own health, is usually less than 30% or less than 20% of the whole spectrum of health. We have control, and the vast majority is beyond our control. So that is a misperception, thinking we have full control or near full control of our health. So I lost track of your other questions. I was focusing on this particular question. Can you repeat the other questions, Warren?
One of the other comments was if we allow everyone to access care, then the general public will have to wait in long lines and not get the care we should be entitled to.
The waiting time issue, yes. The waiting time issue is interestingly closely related to the issue I mentioned, largely being overlooked, governance. That means if we are to implement a universal healthcare system, we have to have a very public-oriented democratic process of governance, meaning people, their voice, their value, their preferences will be well reflected into the system. So waiting time is part of the system. That means in a good governance structure, the general public can voice their preference. How much do we want to invest in this system? By invest, it means tax. How much tax we are willing to finance the system versus waiting time. Because the lower the waiting time require higher investment, meaning higher tax. So there's always a trade-off. And Sweden makes a very explicit rationing that they want people have limited access to CT scan and MRI based on their epidemiological data to show the population need. And that's how they restrict the number of MRI and CT scan, and for that matter, open heart surgery and organ transplant surgical teams, etc. So these are the kind of decision that require the public input. There's no such thing as expert on those value judgment. These are pure value judgment. How much we are willing to contribute in tax versus how much we think is appropriate waiting time for each situations. So the short response to that question is a universal healthcare system doesn't necessarily lead to a long waiting time. Taiwan is a good example. As a matter of fact, Taiwan's universal healthcare system make it too easy to access, too short a waiting time. And there's a concern about unnecessary use or overuse. And I think that there's one more question, right? Before we get to Linda.
Oh, I think that's enough.
Okay.
And if there's anything left at that is, would you expect to hear comments like that being popular in Taiwan?
Yes, there from time to time there were people who raised that questions, but fortunately these are extremely minority because people value and love their system. The government actually contracted private firm, public opinion survey firm, since the beginning, 1995, the beginning of the system. They track the public opinion poll in terms of their preference for the system, whether they are favorable or not, every quarter. And so their federal public favorite percentage has systematically rising from the early years. It was about 70% to the most recent decade, persistently above 80% of the public who are satisfied with the system. Thank you. And Linda.
Yes, thank you. And it's interesting. My question really follows what Warren was just talking about. What struck me as you were speaking and as we were looking at those slides, when you were talking about values, individualism versus communitarianism, there was a word there I hadn't seen before, but and that it struck me as unfortunately, one of the most probably biggest challenges we have in the United States in implementing something like this and getting the population on board with it. And it's that individualism, it's that misperception that we get what we deserve and that we've earned everything we've gotten, and that if people would only do the right thing, that they would, if you're a good person, you come out ahead, or you have good health, or those kinds of things. And so it's very it's difficult for me when I see that slide and hear the things about those values, and that's just the one that stood out the most to me, but there were others. What an uphill climb we have here to convince people that you're only, that it can happen to anyone. People don't understand that it can happen to anyone. And I'll tell just really quickly a very personal story. My husband was very healthy person and very conscious of his health. Nutrition, he took nutritional classes. He was very active, took care of his skin as far as protecting. And then he was struck about 15 years ago by a very rare condition, chronic condition that has no known cause, which disabled him. And he was working full time. He was a vice president at a local company. He had to go to part-time work. He lost his health insurance because he had to go part-time. He lost his ability to do all the things he loves, like bicycling and climbing and kayaking. And it was through no fault of his own, right? He did everything right, and this thing happened to him. And I don't know how to help people I don't know how do we change that, or can we change that fierce individualism that sort of defines the American values, and getting people to understand that you don't have that control. I don't know how we do that. Do you have in any of these cases in these other countries where you've seen, did they have to come that far? Did anybody else have to come that far to get here?
Yeah, I fully aware and understand what the issue you raised. In 2013, I helped organize a town hall meeting at Corvallis Public Library. And at that time, I specifically set aside 1 hour after my short presentation. I set aside 1 hour, and we had about 120 some participants. It was a good turnout. And I divided those participants into, I think, 10 small group. And I invited my graduate student, about a dozen of my graduate students, to help moderate each small group discussion and let the participant to raise their concern about universal health care. And I was walking around to listen to those concerns. And one group I happened to listen to. One generally young man raised exactly that concern. Why should I pay for other people's irresponsible, he used the term, irresponsible behavior, make them unhealthy? And interestingly, in that same small group, there's one young lady, and she objected to that young man's comment. She said, I was born genetically with high cholesterol level since I was a baby. I'm a vegetarian. I do all the exercise, but that still doesn't prevent me from getting very high cholesterol level because I was born with the condition. And I wonder how that man who raised that objection did not make any comment or response, but I wonder whether this young lady's personal experience have touched him to the extent that to recognize there are so many factors influencing our health that's beyond our control. And it's not just so-called irresponsible behavior. Because as I mentioned, the rough estimate is we don't have control for more than 20% of our health. And environmental factor is one of the largest factors that affecting our health, that we have almost absolutely no control on the environmental factors. But again, people who are diehard individualistic, it's very difficult for them to listen to know there's a such thing as social responsibility, because all they recognize is individual responsibility. And let me also very briefly comment, you mentioned about you are not familiar with the term communitarianism. That's the philosophical and ethical principle lie behind many nations' universal health care. Communitarianism is almost a direct opposite to individualism, because individualism never think there's a such thing as a society. Margaret Thatcher's famous quote perfectly reflect that. In numerous press conferences, Margaret Thatcher said, there is individual and family. There is no such thing as a society or community. And that statement may sound extreme, but I don't think it's extreme. It's exactly how many individualist Americans feel. There's no such thing as community or society. There's only individual and family. Whereas communitarianism would like to think individual not just as an individual, but individual as a member of a community, as a member of society. So that's the underlying philosophy of communitarianism. And in addition, another important trait of communitarianism, besides individual thinking, individual as a member of the society, the other important trait is the society will always look after people at the bottom. Thank you for your comments. And then we have Alex and then Nancy.
I think Mark had his hand up before me.
Mark. Okay, Mark, please. Yes, Mark.
Actually, my question was very similar to Linda's. What do we do about, because it seems to me we've had some information about healthcare in the United States, showing the United States way behind some other nations for quite a while now. In my I teach a child development class, and you know the textbook brings out that of 37 industrialized nations studied in 2014, the US was 37th in infant mortality. You know, we had the highest rate of infant mortality, and yet we continue with this system. I also just wanted to comment, if people are worried about long waits, it's happening now. I tore the bicep muscle right off the bone of my arm and waited 6 weeks to get surgery. And more recently was hospitalized through the emergency room for a gallbladder that decided to die before the rest of me. And they told me, you know, you're close to going into septic shock here. You have an infection in addition to the gallbladder and da-da-da. And yet I lay in a hospital bed for 2.5 days waiting for a spot to get surgery with this potentially very damaging illness. Anyway, I appreciate, and from that experience, I appreciate what your comment that we don't know. You know, we walk around thinking we're fine, but there's a time bomb about to go off. You know, and we simply walk around not knowing this. We all have some genetically pre-planned issues. But anyway, I'll stop. Alex and then Nancy.
Thank you.
I asked a question before, Nancy. If you want to go, I can go after you in case we run out of time.
My question is related to the conversation a couple of minutes ago, so maybe I'd better go before it's totally lost and irrelevant. And it has to do with the concept of individualism versus communitarianism, which it appears is labeling that's being used for these concepts. And I don't know what discipline, political science or what discipline, but it reminds me of a concept
in psychology that I published some work and did some work with, in which we talked about individualism and collectivism. It's a very similar idea, and the idea is that there are individualistic values that people hold, and then there are these people with collectivistic values, and that's what they hold. And this is the way that the research was conducted. And then we came along and we pointed out that this is a bimodal concept when we are not bimodal thinkers, we humans. And what we asked, simple question, what would happen if you didn't force people to choose between individualism and collectivism? What would happen? And so we would give the same items, but it would be, you strongly agree or not agree to them. And it turns out that first we did with college students, but we analyzed the larger data sets as well. It turns out that if you do males and females and whites and ethnic minorities, and this is college students, that it was the white males that were the individualists and were avoiding the collectivists. But in terms of the high scores, so the white males had the high individualistic score, low collectivist score. But the white females, the ethnic minority females, and the black Hispanic, we didn't have enough to separate black out, but the minority, I think minority males were all high on individualism and collectivism. And so I think, I wonder if we're not really missing a boat if we don't stop thinking of all these things in bimodal ways and start thinking of a more value synergism and how to bring people together around the clusters of values that may or may not be salient in your mind at any particular moment, but can be raised to conscious or lowered to conscious, depending on how you're messaging. And I just wondered what it's like in your field and what it's like in general, and what do you think about this idea of trying to decouple this individualistic versus collectivistic or communitarianistic perspective?
Well, let me try to use a brief time and concise method to explain, because you're touching on a very complex issue about how society, particularly how free society, deal with those philosophical issues in terms of individualism, in terms of individual liberty. And this past springtime, I happened to teach a graduate course in related to public finance. And the field of public finance or public economics has a classic way since late 1970s to address this issue in an economic way, meaning in a default free market society, what is the rationale for the state, for the government to intervene in people's activity? And within that framework, within the public economic and public finance framework, Musgrave, there were two couples, Musgrave and Musgrave, developed this scheme by classifying all goods and services into three categories: private goods, merit goods, and public goods. And for private goods, the key trait is the consumption of which does not affect others. So with that definition, the vast majority of our goods and services belong to private goods. And in that case, in a free market society, government should avoid, intervene, or engage, except when necessary, regulating the safety or hygiene issue. Other than safety, hygiene, and prevent monopoly, government should not intervene. And then the last category, public goods, that is the goods and services that has strong external effect. And also it cannot exclude the free riders. So for public goods, no private market is capable of provide. Only government can provide. And there are very few goods belong to public goods, such as environmental protection, such as national defense. So not many fall into that. So the most complex and tricky one are the something in the middle called merit goods. The merit goods are the one that the consumption of which have external effect. It affects others, but it also shares the same trait as private goods, that you can exclude the free riders, meaning you can set up a payment system, require only people who pay can benefit from it. But because the merit good involve external effect, in the economic term, it's called externality. That's the economic jargon. Plain English meaning external effect. And two of the most contested issue or goods fall into the merit goods: healthcare and education. Both healthcare and education have external effect. So if we have only private education, the overall national educational level will be much lower, and the industry will not get enough labor force. So this is a huge external effect. Likewise, if healthcare is completely private, then the low-income people, well, not just low-income people, the way our price goes, most middle and low-income people won't have access to healthcare in this country. That will also affect our labor force. So this is an example of external effect. And of course, the current pandemic is even a greater example of the merit good, because no private industry, no market is capable of controlling pandemic. Only government can control pandemic. And can you imagine if the government didn't intervene for this pandemic, we won't have the vaccine available, and more people will die, more people will be infected. So this is from a public finance way to address the issue of individualism. So, and to back to Nancy, your comment, how can we find a middle ground? I think this is the perfect middle ground. For the private goods, the vast majority of the goods services we are used, you can think as an individual. You don't have to worry about the community. You can act and think as an individual. It is for those limited merit goods. And for public goods, we don't have choice. Unless we don't want national defense, unless we don't want anyone to protect our environment. Because the private market is incapable of addressing those issues. So it's the issue at hand in terms of to what extent we want to abide by individualistic thinking versus the communitarian thinking. These are all focusing on the merit good issues, such as education, such as healthcare. And some other public services also fall into the merit good, such as public transportation. So it's only this limited subject that demand us to think more like communitarianism versus individualism.
Can I just ask a quick question follow-up? So in other words, you said
Nancy, it needs to be fairly quick. We're starting to run out of time.
So in a way to interpret what you said, if we want to sell healthcare and education, we start at the middle goods level, but more emphasize what takes it to the public level. And that's the sweet spot in terms of where we would want a message?
Yes, the merit good, the nature of merit good, meaning the goods and services have external effect. It doesn't just affect individual, it affect others, affect the whole
education.
community.
Yeah. So that's the education.
Yeah. Education and health too. healthcare.
Thank you.
Alex.
So do we have time for a quick question, Mark, or is that okay?
Sure, we'll do one more and then we'll start to wrap up.
Okay, thanks, Dr. Chi. I'm not sure you can answer this if it's out of your wheelhouse or not, because I know you're mainly comparing countries. My question had to do with below the country level, like in the provincial or regional level, because as you're aware, the task force is working on single payer here in Oregon. And one of the issues they're dealing with, like, is what's going to happen with if we implement it with the states around us. Like they're already talking about, covering people out of state. The consultants, the actuaries, did an assessment of how many people would be moving to Oregon for healthcare versus maybe fleeing the state because of higher taxes, and they came to the conclusion it was just a wash. But I'm just curious. I mean, have you seen any input on that as far as if it's not implemented nationally, if say we implement it on a state-by-state basis? Like what happened like with Canada, with Saskatchewan doing it first, and was there inter-regional or provincial issues that maybe we could learn from other countries that didn't implement it nationwide? Does that make sense?
Yes. Canada may not be a good example for us to follow. By good meaning the feasibility, because it only around 3 years after Saskatchewan implemented it, the whole nation implemented it. So there was not a big gap. So I think that the issue you raised is a concern of there's a big gap across state. So that's why I say Canada may not be an appropriate example for US to follow, because there's a very short gap between Saskatchewan and the whole nation. And if any state like Oregon implement universal healthcare, we are likely to see a long gap between state, across state, and between state and nation. And it is hard to estimate the impact of inflow and outflow of migration across state. As you mentioned, if Oregon implemented universal healthcare, we may attract people who want universal healthcare from our neighboring state. And we may kind of push people who dislike universal healthcare to migrate out of state. And my guesstimate is such impact may not be dramatic. There will be impact, but I don't expect such impact to be very large, but it's very significant. That's just my best guesstimate, because people don't just choose to move to a state simply because that state has universal health care. Usually, particularly for the non-elderly people, they still need to have a job. Unless they're independently wealthy. Otherwise, a job is still probably the #1 issue for people to consider. And that may make Oregon's job more attractive, because with universal health care, the healthcare cost of production of employment will be much lower than other states. And that may attract employer and investor to come to Oregon to set up industries and employment. So in summary, there will be both positive and negative inflow and outflow of migration with the universal healthcare.
Thank you.
Okay. Any quick last comments or questions? Well, then thank you very much, Dr. Chi. This has been an absolutely wonderful presentation, and really admire your ability to deal with questions so spontaneously coming at you.